Okay, welcome everyone. This is the National Hispanic Medical Association's Congressional Briefing on Cancer and Obesity in Hispanic Communities. I'm Dr. Elena Rios, President and CEO of the National Hispanic Medical Association, and also of our National Hispanic Health Foundation. We have congressional briefings to be able to educate our congressional staffers and national advocates about the importance of policy issues that impact the Latino community and other diversity communities. And we're very, very proud to focus on issues that we actually have supported over the years many times. And it's really under the topic of prevention. We need to think about investing more dollars and more congressional policies into prevention so that our communities can have healthier quality lives and be more productive in society. After all, we are going to be a majority-minority country sooner than later. So in terms of prevention, let me just say that obesity is a very fundamental disease that is now recognized as a chronic disease, and nearly 1/2 of all Latinos and Blacks in this country are now living with this chronic disease and facing the consequences of complications like cancer and heart disease, diabetes, and a lot of other issues. It's projected by 2030, in our lifetime, 1/2 of all Americans will be having to face obesity and the consequences of this #2 leading cause of preventable death after smoking in this country. The NHMA has been very focused on obesity, supporting the TROA Act, which is the Treat and Reduce Obesity Act, which has been introduced in Congress for several Congresses. And that act asks for Medicare to cover medical treatment, in addition, and additionally behavioral therapy, in addition to surgical treatment. The other thing that we've been supporting is the Obesity Bill of Rights, along with the National Consumers League and the National Council on Aging. In terms of cancer, which is the other major disease that we're focused on here, and especially the Biden administration, we have supported the importance of the Cancer Moonshot, and the National Cancer Institute really focused on the importance of cancer research and having diversity in the researchers as well as the participants in clinical trials. We have long called for the increase in our presence within medicine, not only numbers of Latino doctors, but numbers of Latino researchers and principal investigators. And it's our National Hispanic Health Foundation that has started the National Center for Hispanic Health Research, along with our corporate advisory board and our board of directors. We have been working for at least the last 3 or 4 years on developing our own databases of Latino principal investigators in cancer and in others, and we're very happy to work with the American Cancer Society on these efforts. And let me just say that we work with pharma companies on the obesity efforts because they're involved in creating what we think are cutting-edge medications for our physicians to use in our communities. However, there are high costs involved with the new medications, and we think for Congress to know that we really do need to take a look at how can we reduce costs. And we think it was great that the insulin cap was put on through Congress. We want to congratulate Congress members and your offices for doing that, so that more of our community can actually live quality lives, having more affordable medications. So let me just go ahead and start. I want to thank everyone. We have a great panel, and we have just a few housekeeping rules. We want everybody to keep their microphones muted. The recording of this congressional briefing will be at the nhmamd.org and our YouTube channel, National Hispanic Medical Association. And the recording and slides will be available about a week after the event. And if anybody has any questions, please put them in the Q&A box. We will have the discussion of questions at the end of the session. And it gives me a great pleasure to introduce our first speaker, Congressman Raul Ruiz. He's a good friend, good champion. He has been the champion for Latino health and sits on the Energy and Commerce Committee. and we're very proud to know him as a friend and colleague, the Honorable Raul Ruiz.
Thank you so much, Dr. Elena Rios. You forgot to mention that I too was, and perhaps still, a member of the National Hispanic Medical Association ever since I was a medical student and resident, and my whole upbringing as a Latino pre-med student, medical student, residency resident, and now physician in Congress has all been aligned with National Hispanic Medical Association. So this is an influential organization that has done great work. And now as a member of Congress, I fully support NHMA's vision that you've brought, that you've created. And I must say, Dr. Rios, that because I always like to tell this story, but Dr. Rios has mentored me since I was a pre-med student at UCLA. When she was in grad school there. And I remember that time we sat on the bench and you basically counseled me on what I needed to do to get into medical school and how to think through my progress. So mentorship does work, and we have to keep building these ladders for others to climb on. So I appreciate the ladder that you built for me, Dr. Rios.
Thank you.
I want to say hello to everyone, especially the guests that are going to be the panelists. Thank you for being here and for participating in this very important topic. I'm Congressman and Dr. Raul Ruiz, representing California's 25th Congressional District. That's the southeast corner of California. Thank you all for being here. I would also like to thank Dr. Rios and the National Hispanic Medical Association, the American Cancer Society, Cancer Action Network for hosting this briefing on such an important topic. And as some of you may know, I'm an emergency medicine physician, a public health expert. And for years, I treated patients in Boston, in Pittsburgh, and in the Coachella Valley, and where home is for me, with a multitude of all these illnesses that we've talked about: obesity, cancer. Usually when they come to see me, it's because of some complication, of some emergency, of some illness that is life-threatening that could have been prevented. And in treating patients primarily in rural, underserved, and underrepresented areas, I have seen the real need for improvements in our healthcare system, not just in coverage, but also in the way we deliver and the way we educate our population to improve their health. And this is one of the main reasons why I ran for Congress in the first place. As a physician first, non-politician, I decided to step out of the halls of the emergency department and into the halls of Congress. Because I am a disaster specialist by training, I find myself well at home here in Congress for our nation's man-made disaster. But I just wish I would have also dual trained in psychiatry, because God knows we need a psychiatrist here to deal with some of the crazy that this Congress has been dealing with. And it's how I've approached my work in Congress is as a non-politician, but as a public servant, physician trained in disaster, humanitarian aid, and public health to really help our nation through its biggest obstacles. And for the past decade, I've been fighting for legislation to improve access to high quality, affordable healthcare for all patients. That includes making sure we have a robust healthcare workforce to care for patients, that can understand our patients, that are culturally sensitive and in tune and competent to the needs of patients from diverse backgrounds, and that can also speak various languages that our patients can understand. Because being culturally sensitive isn't just theoretical, isn't just a feel-good notion. It is shown through scientific studies to improve patient outcomes. Patients that feel understood, that have treatment recommendations, in a form that is congruent with their cultural understandings have better outcomes. And science in medicine is about having better outcomes. So it is a scientific fact that having culturally sensitive providers to understand the cultures and the diversity and to speak the language of their patients will have better outcomes. But it also means increase of screenings for disease and the development of innovative treatments and medication. And those are things that I've been focusing on as well. But I would argue most importantly, that means making sure patients have access to these treatments and screenings. Oftentimes in our country, we push for innovation, we push for cutting edge technology, but then when we get it, we celebrate it, but only the rich and powerful have access to it. And we need to make sure that all the good that comes out of our brightest brains are accessible to everybody in our nation, regardless of their ability to pay, because they suffer the same ailments as everybody else, and they need the same treatment as everybody else. So today we face an obesity epidemic in our country and in our community. The Hispanic community, as Dr. Rios was mentioning earlier, in particular, faces high rates of obesity. Obesity is a disease, and there are steps we can be making to address it head on. And while there are medications to help treat obesity that are very promising, that work, Medicare can't cover them under current law. That is why I co-led the bipartisan bill with Representative Wenstrup, Representative Miller Meeks, and Representative Gwen Moore that would change that. So HR 4818, our Treat and Reduce Obesity Act, or TROA, would allow Medicare coverage of anti-obesity medications. It would also allow more qualified healthcare providers to administer intensive behavioral health therapy, because studies have shown that when you combine either the medication or with surgery or with behavioral health treatments, the combined modality, you have better outcomes than if you just do medications alone. So that's why that's a very important component of this bill. And so this is a vital step towards combating the obesity epidemic and ensuring that readily available treatments get into the hands of those who need them the most. As we improve the way we treat obesity, we must also address comorbidities associated with it, including cancer. So we know that catching cancer at an early stage leads to better patient outcomes, and timing is of the essence. So as a physician, I've witnessed firsthand the positive impact that early detection of cancer has on patient outcomes, because you can prevent its growth, you can prevent its metastasis and save lives. And I've also seen the fatal consequences that can arise when a diagnosis comes too late. So there have been promising technological advances in early detection, but more work needs to be done so patients can access these tests. So HR 2407, the Nancy Gardner Sewell Medicare Multi-Cancer Early Detection Screening Coverage Act, led by Representative Arrington, would give Medicare the authority to cover blood-based multi-cancer early detection tests, including future test methods, once they are approved by the FDA. And that's very important. And I'm an original co-sponsor of this important bill as well. So these diagnostic technologies are already out there. So let's not delay giving the most vulnerable in our community access to these potential life-saving screenings over coverage disputes. So while we work to get these bills to the floor for a vote, progress is being made. So just yesterday, the Committee on Energy and Commerce voted to support reauthorization of the National Breast and Cervical Cancer Early Detection Program, getting the bill one step closer to a full vote. So this is very important for NHMA and for me, because this goes to the heart of health disparities. We know that Latinos, Latinas throughout our country have higher rates, for example, of cervical cancer, of other type of cancer, which is multifactorial, One big factor is the lack of access to preventive services, to screenings, and it goes undetected. And so they're more likely to die because they didn't have coverage, they didn't have access to doctors. And so by being able to address disease specifics, solutions, being able to address disease-specific solutions that are diseases with these health disparities in our communities, we are able to take a multifactorial approach to reduce the risk and reduce the barriers in order to eliminate health disparities between different groups. And so these two bills are ways that we tackle health disparities and we tackle equity. Now, health disparities is different than equity, and equity does not mean equal. It does not mean equality. So it's very important that we understand that, because there's a lot of confusion even within the Democratic space, the liberal sphere, on what equity means. And equity does not mean equality. It does not mean being equal. Equity is a public health term that basically looks at the individuals with the highest risk, the individuals that have the highest need, those that are sick, and that those individuals get the resource attention. So it doesn't mean the equal distribution of resource. It means that you target the highest risk to reduce their vulnerabilities to illnesses by paying the most attention to those highest risks. And it makes sense, especially in a pandemic with communicable diseases. And it makes sense in addressing the disparities of health that we see around our country. So when we fight for equity, we're fighting to make sure that people that need the resources the most get access to those resources. And in this case, if you're seeing one population dying of certain cancers the most, then we got to make sure that population gets access to the early cancer screening detection tests. And we have to intentionally target those individuals and have reduced those barriers. Now, obesity, there are certain populations with higher obesity than others. So we have to intentionally ensure that those populations with the higher obesity rates have access to the medications that will help them with their obesity. So these bills go to the heart of health disparities, and they go to the heart of equity. And with that, I invite all of us to join in this effort to advocate for these pieces of legislation to get past the finish line. Thank you.
Very much, Congressman Raul Ruiz, for your words of wisdom. And I just put in the chat, I think what you're talking about is reallocation of investments into prevention and to unresourced, or I said low resource communities like Latinos and African Americans, Native Americans. And thank you for your wisdom on the health committees of Congress. I just wish that everybody else would think the same way. So whatever we can do to get more support, we're here to educate all of our audience on joining with us and supporting all the bills that you mentioned and more. And I look forward to working with you in the future. And I hope you come to our 30th anniversary summit, April 12 and 13 in Washington, D.C. at Capitol.
30th
Hyatt
anniversary.
Regency.
Wow, that's
30
amazing.
years. And
I hope to be there too.
I really want you to be there, but we'll get you that information. Thank you very
Awesome.
much.
Thank you, everybody. Enjoy the talk.
Okay. Now we
Bye-bye.
move on to our experts for healthcare. We're going to start with our expert on obesity, Dr. Mackenzie. Maricela Castillo Mackenzie is one of our fellows, NHMA Leadership Fellows. She is the CEO and co-founder of Elle MD, Weight Loss and Wellness. Marcelo, take it away.
Hello, good afternoon. Thank you so much for the invitation. I'm very honored to be here and be presenting with Dr. Tera and Dr. Jean today. So we're going to be talking about this alarming problem that we have in the Hispanic community. First, I want to talk about, the Hispanic community in the U.S. So as we know, it is the largest and fastest growing minority group. Currently, there are about 62 million Hispanics, representing 19% of the population. By the year 2060, the Hispanic community will represent 28% of the population. They are our neighbors, our colleagues, and our family members. Understanding their health concerns is crucial for the well-being of our nation. Next, please. So in this graph, you can see the projected Hispanic population from the year 2020 to the year 2060. This is from the Census Bureau. And you can see where we are right now. We're about 19%, 62.3 million, but you can see where we're going to be in 2060, 111.2 million. Next graph, next slide, please. So the alarming rise of obesity in the Hispanic community. Statistics are very concerning. Obesity rates among Hispanics are alarmingly high right now. In 2020, 45.4% of Hispanic adults were classified as obese. The national average is 41.9%. According to the Office of Minority Health, nearly 80% of Hispanic women are identified as obese or overweight. The Trust for America's Health, it reports a steady increase in obesity rates within the Hispanic community over the past 20 years. This highlights an urgent need for intervention. Next, please. In this graph, we can see the prevalence of obesity in the Hispanic community from the years 2017 to 2018. This is from the National Health and Nutrition Examination Survey. So we can see in the light green color, the first column where we see the total, we can see that the Hispanic community is the second highest prevalence in obesity, following the non-Hispanic Black community. In men, it is the number one, the Hispanic community occupies the number one prevalence of obesity. And in women, it is the second highest prevalence in obesity, following the non-Hispanic Black. So these numbers are pretty alarming. Next slide, please. So understanding obesity. So obesity, as it was mentioned previously, it is a chronic disease. It is characterized by an unhealthy amount of body fat accumulation that can negatively impact health. It is measured by using body mass index, or BMI, which is a calculation based on height and weight. A BMI of 30 or higher is considered obese. It is the most common chronic disease in the Hispanic community. The estimated annual medical cost of obesity in the U.S. was nearly $173 million in 2019. Next slide, please. So what causes obesity? It is complicated. It's not as simple as eat less, exercise more. That's something that we used to hear very often previously. But as research has evolved and there's new treatments and new research has come out, then we can see that this is very complex, but there's ways to help our patients and our community. I really like this figure, which is from the European Association for the Study of Obesity. So I like it because it shows the 12 causes of obesity in a very clear, simple image. So we have individual factors and environmental factors that can cause obesity. So as we can see in the blue color, we can have the individual factors. So we have genetics and epigenetics, nutrition, hormones and metabolism, exercise and activity levels, sleep, stress and immunity, cognition and addiction behaviors, and I would add gut health. The gut has a lot to do with obesity too. And environmental factors, we have workplace and business culture, community and lifestyle planning, food policy and production, healthcare and policy delivery, finances and funding, education system, and parenting. So as you can see, it's a little bit more complex than what we thought. And all of these causes, or all of these factors, can cause obesity in a patient or in a person. And most importantly, the most important concept of all, it's not a choice. It's never a choice. Next slide, please. So, health consequences of obesity. Obesity significantly increases the risk of various chronic diseases, as mentioned previously too. And it is the root cause of heart disease, which is the leading cause of death in the US, stroke, type 2 diabetes, and certain types of cancers, sleep apnea, and osteoarthritis. Very importantly, the first 4 chronic diseases that I mentioned are the leading causes of mortality in the Hispanic community: heart disease, stroke, type 2 diabetes, and certain cancers. Next slide, please. So obesity and cancer care, it is a very dangerous link. Obesity is a significant risk factor for several cancers. It has been linked to at least 13 different types of cancers according to the American Cancer Society. As we can see on the figure on the right side, we can see the cancers associated with overweight and obesity: meningioma, adenocarcinoma of the esophagus, multiple myeloma, kidney, endometrium, ovary, thyroid, breast, liver, gallbladder, upper stomach, pancreas, colon, and rectum. So what happens? Excess body fat can fuel cancer growth and make it more aggressive. So it's very important that addressing obesity is key to prevent many of these cancers. Next slide, please. The disproportionate impact on Hispanics. While Hispanics have a lower overall cancer incidence than non-Hispanic whites, the gap is narrowing, unfortunately. Hispanics are more likely to be diagnosed with some obesity-related cancers like liver and pancreatic cancers. We're going to hear more about this. And this trend could lead to a significant future health burden for the Hispanic community and the healthcare system. Next slide, please. So what is the cost of obesity-related cancers? The direct medical cost of treating all cancers in the US was about $181.5 billion in 2023. Interestingly, obesity-related cancers account for nearly 43.5% of the total direct cancer care expenditures. And we can see this in the this graph on the right side. This was a research study that was conducted by Young, Rag et al., where they basically studied the excess cost and economic burden of obesity-related cancers in the United States in 2019. So we can see in the graph how national prevalence in the lighter yellow, we can see other cancers are about 73.2%. Obesity-related cancers are about like 26.8%, and this is represented in the darker yellow. But if we see the total direct expenditure for cancer care, both numbers are very similar. So for other cancers are 46.7 billion, and for obesity-associated care, it's 35.9 billion. So obesity-related cancers significantly contribute to the overall cost of cancer care, and are a significant driver of healthcare costs. Next slide, please. Our call to action. The obesity cancer link in the Hispanic community presents a critical public health challenge. Investing in solutions is not only morally imperative, but also economically sound. We urge you to champion the following: recognize and address obesity as a chronic treatable disease. Promote culturally sensitive healthy eating and physical activity in Hispanic communities. Increase access to affordable, healthy food, and address social factors impacting the health of Hispanic communities. Support the Treat and Reduce Obesity Act, bipartisan legislation that provides Medicare beneficiaries with access to safe, effective, and life-saving treatments. Support the Obesity Bill of Rights and its adoption in clinical settings, which is the medical guidelines empowering patients to receive equitable treatment free of bias or discrimination regardless of weight. Invest in research to better understand and address obesity-related disparities in the Hispanic community. By working together, we can create a healthier future for all Americans, especially the Hispanic community. Thank you very much.
Thank you, Maricela. And we now are going to go to our next speaker. Our next speaker, Dr. Lauren Tera, Senior Scientific Director epidemiology research at the American Cancer Society. She specializes in the etiology of breast and hematologic cancers with the focus on risks that can be modified through behavior change, medical interventions, and policies. Dr. Tera.
Thank you so much, Dr. Ruiz. Hello, everyone. I'm honored to be here today to discuss this important topic. I will echo many of the comments of the previous speakers, Dr. Rios, Congressman Ruiz, and Dr. Mackenzie, but mostly this is in order to underscore the importance of these issues. Next slide. So as you've heard, the Hispanic community is a large and important group of constituents in the United States. More than 63 million people identify as Hispanic or Latino in this country, and that accounts for 19% of all of the people who live here, making it the largest and youngest community of color in the US. Next slide. When we try to understand cancer in this community, it's important to look at the raw numbers sometimes. More than 176,000 new cancer cases are diagnosed among Hispanic people in the United States each year. Here on the slide, you can see the most common cancers that are diagnosed in order, with the most common at the top and least common at the bottom. In general, the most common cancers among all Americans are breast and prostate, just as you see for Hispanic people in this country. But after you get from that top level of cancers, you start to see some differences. One of the particularly concerning differences is for uterine corpus, which is also known as endometrial cancer or just uterine cancer. That is a cancer for which rates are leveling off for other populations in the United States, specifically for non-Hispanic white women, but increasing for women of color. For Hispanic women, this increase is about 3% per year. And this difference is likely largely related to increasing incidence of obesity. Next slide. Another concerning statistic among Hispanic people in the US with regard to cancer is that Hispanic people are less likely to be diagnosed with cancer at an early stage than white Americans. This is important because, as Congressman Ruiz mentioned earlier, cancers that are diagnosed at an earlier stage are easier to treat with treatments that are more tolerable for the patient. Next slide. Later stage diagnosis is a major factor in whether or not people will survive their cancer. Before the COVID-19 pandemic, cancer was the #1 cause of death among Hispanic people in the US. In 2020, COVID surpassed cancer because of the disproportionate burden on the Hispanic community. However, we're still learning all the indirect ways in which COVID has and will impact our communities. But one thing we know is that cancer screenings and early stage diagnoses of cancer are down. Are down because of the pandemic, which will likely have a long-term impact on higher cancer mortality. And we know that cancer is and will continue to be a major cause of death for Hispanic people in this country. Next slide. So what can be done about cancer? Though advances in treatment are amazing, wouldn't it be even better if people did not get cancer at all? An estimated 42% of cancer cases and 45% of cancer deaths in the US could potentially be prevented by addressing things that we already know contribute to cancer. Of these, excess body weight, accounts for the second highest proportion of cancers, second only to smoking. So as a reminder, sorry, can you go back one slide? As a reminder, obesity is a disease. This is something that all of the previous presenters have said, but I just think really needs to be underscored for people to understand that this is a disease in which people have an unhealthy amount or distribution of fat that is a disease in of it itself and puts people at higher risk for other chronic conditions, including cancer, of course, but also diabetes, high blood pressure, cardiovascular disease, stroke, and premature death, most important. Next slide. So again, to underscore this point, obesity and overweight are a major problem in the Hispanic community. It's a problem for all of Americans and all of people who live in this country, but the rates are even higher among the Hispanic community in this country. More than 80% of Hispanic adults and 45% of Hispanic adolescents have overweight or obesity. This is a huge problem that is been increasing over time. Over the last few decades is leaps and bounds higher now than it was back in the 1990s. When we compare these 80% and 45% among Hispanic adults and adolescents, we compare them to more like 70% and 33% of non-Hispanic white adults and adolescents, showing a health disparity in the disease of obesity. Next slide. So you heard from Dr. Mackenzie that there are 13 types of cancer for which excess body weight is considered to be causally linked to these types of cancer. However, there are additional links to more rare or specific subtypes of cancer that continue to emerge. Much like for smoking, as we continue to do research, we continue to uncover links between excess body weight and cancer, and have a better understanding of the broad ways in which this risk factor can impact many, many different types of cancer, and also other chronic diseases. Next slide. So again, something that you've heard echoed is that obesity is a complex problem. It's not just a matter of willpower. It's a problem that requires many hands and many solutions. Next slide. When we step back and look beyond the individual level, we can see the impact of neighborhood characteristics on the issue of obesity. Here we see that food insecurity is a major issue in the Hispanic community. More than 20% of Hispanic individuals, compared to 80% of white individuals in the United States, experience food insecurity, meaning that they are uncertain or unable to acquire enough food for their family because of insufficient money or other resources. On this map, we can see the percent of households that live more than 1 mile from a grocery store next to a map of obesity. The grocery store map is on the left and the obesity map is on the right. From here, we can see that many of the same places where it's difficult to access fresh fruits and vegetables and other fresh foods are often the same areas with high rates of obesity. This is not a coincidence. Next slide. And beyond access to healthy foods, neighborhood features like sidewalks, bike lanes, street designs that flow traffic and make it safe to cross, to have access to parks, gyms, shops, and other destinations within walking distance make a huge difference in how active we are in everyday living. Low-income and minority neighborhoods have fewer recreational facilities and walkable communities than wealthier and predominantly white communities. And these things contribute to many of the racial, ethnic, and socioeconomic disparities in obesity rates. Next slide. And last, again, something that's been alluded to today already, many Hispanic individuals face financial, structural, and personal barriers to healthcare. I said at the beginning that Hispanic people are more likely to be diagnosed at a late stage of cancer. One major contributor to this is because more than 1/4 of all Hispanic adults under age 65 have no healthcare coverage or usual source of medical care in the US. This is the largest percent of all racial or ethnic groups in the US to have no insurance and is 3 times higher than among white people in the US. Next slide. So in summary, racial and ethnic disparities in obesity underscore the need to address these social determinants of health, such as poverty, education, and housing, to remove barriers to health. Neighborhood design and access to healthy, affordable foods, convenient and safe places for physical activity can impact obesity and in turn, cancer risk and mortality. And importantly, as a researcher myself, I would be remiss if I didn't mention that sustained funding for research is essential to continue to make strides in cancer prevention strategies and interventions, early detection of cancer, and effective treatments for both obesity and cancer. Thank you so much for your time.
Thank you, Dr. Teras. Great speeches so far, and I think we saved the best for last. We now have from the cancer moonshot of the Biden administration, Dr. Jean, Pascale Jean, and I hope I said that right. I know you're French, but I just wanted to say that we're very appreciative of all the administration's work to take a look at cancer and make it such a real focus for this administration. And I think that we totally support the importance of research and innovation and access to our communities to get earlier screening and treatment. So thank you, and let's hear your wisdom. Thank you.
Thank you. Thank you so much for the invitation. As noted, my name is Pascale Jean, and I serve as the Assistant Director for Nutrition and Health at the White House Office of Science and Technology Policy, or OSTP. The mission of OSTP, where the Biden Cancer Moonshot is housed, includes strengthening and advancing American science and technology, working with federal departments and agencies and with Congress to create bold vision, wise policies, and effective, equitable programs. Engage with external partners and ensuring equity, inclusion, and integrity in all aspects of science and technology. Next slide, please. During our time together, I will provide information about the Biden Cancer Moonshot and its priorities, then briefly highlight the impact of obesity in America and the correlation between obesity and cancer. You guys have heard some of those things before. I will highlight the commitment from the first White House Conference on Hunger, Nutrition, and Health in over 50 years, which main goal is to end hunger and reduce diet-related diseases by 2030. Next slide, please. The Cancer Moonshot was reignited in 2022 to mobilize a national effort to end cancer as we know it. The ambitious but achievable goals that we are working towards today built on the first Cancer Moonshot, which was started in 2016 by then Vice President Biden. Through the leadership of President Biden and the First Lady, Dr. Jill Biden, the Biden Cancer Moonshot is mobilizing the federal government, healthcare providers, researchers, patients, caregivers, advocates, and the public to dramatically accelerate progress to end cancer as we know it. Cancer touches every American in some way and is still the second leading cause of death in America. That's why accelerating progress against cancer is a central pillar of President Biden's unity agenda, a set of priorities that Americans from all walks of life can support. Next slide, please. The Cancer Moonshot is a White House-led national effort to end cancer as we know it. We are mobilizing efforts towards achieving two ambitious but achievable goals set by the President and the First Lady. The first goal is to reduce the death rate by cancer by at least 50% over the next 25 years, which translates to preventing more than 4 million cancer deaths by 2047. And the second is to improve the experience of people who are touched by cancer. Next slide, please. The president set up the first ever cancer cabinet to work across the federal government and called on individuals, healthcare providers, and leaders across sectors to set up and take action in 5 key priority areas. Those areas are expand access to screening so more Americans can catch cancer early when outcomes are best. For example, the CDC issued more than $20 million in grants as part of the greater than $1 billion commitment to advance national cancer prevention and control through cancer screening programs, reaching every state and many U.S. territories and tribal organizations. Understand and prevent toxic environmental exposures, such as forever chemicals and the pollution, which we know can cause cancer. The EPA, has part of the implementation of the bipartisan infrastructure law, dedicated $1 billion to accelerate cleanup at up to 80 previously underfunded Superfund sites, and committed $7.4 billion to help states replace lead pipes and service lines, including efforts which will protect millions of families from so-called forever chemicals and other contaminants that may increase people's risk of getting certain type of cancers. Prevent more cancers before they start by reducing tobacco use, and a special interest today, making sure everyone has access to healthy food and getting more people vaccinated against HPV, which cause more cancers. The Department of Agriculture announced the new Agricultural Science Center of Excellence for Nutrition and Diet for Better Health, which is in support of cancer prevention goals of the Cancer Moonshot and part of the President's commitment to improve nutrition for the American people as laid in National Strategy on Hunger, Nutrition, and Health. The virtual center will accelerate research on diet-related chronic diseases, including cancer, and aims to translate research into impactful solutions that improve population and public health and well-being. Next slide, please. Driving new innovation and deliver the latest progress to patients and communities so that all families benefit from breakthrough advances to prevent, detect, treat, and survive cancer. As part of his Unity Agenda last year, President Biden called on Congress to establish a fund, ARPA-H, to drive breakthrough in cancer and other diseases. He has since delivered results, working with Congress on a bipartisan basis to invest $2.5 billion in ARPA-H, leading in part to 2 new programs. In July 2023, ARPA-H announced the launch of the Precision Surgical Intervention Program, a program aiming to deliver groundbreaking new tools to enable surgeons to successfully remove cancer for patients through a single operation by better identifying and differentiating between healthy and cancer tissue. And in August 2023, ARPA-H announced the launch of Curing the Incurable via NRA-encoded immunogene tuning, known as CURIT, which with up to $24 million in new funding. So to develop generalized mRNA platforms that can be harnessed to train immune system to more effectively fight cancer and other diseases. By support for patient and caregiver, by helping them navigate the main decision associated with the diagnosis, providing patients easy access to their health information, and driving action to lower drug costs. For example, the Center for Medicaid and Medicare Services finalized a new rule to help people with Medicare navigate cancer treatment and have access to more types of behavioral health providers, certain primary care, and for the first time, allow Medicare payment for services performed by community health workers. Delivering progress in these key areas will spare millions of American families the anxiety, pain, and immeasurable loss that cancer can cause. Together, we can end cancer as we know it. With each of these priorities action, the Cancer Moonshot is working to deliver new ways to prevent, detect, and treat cancer, and ensure that the tools we have and those we develop along the way equitably reaches all Americans. Next slide, please. Being overweight and having obesity increase your risk of getting cancer, as we heard before. But according to CDC, obesity is a common, serious, and costly chronic disease of adults and children that increases risk of heart disease, type 2 diabetes, and many types of cancers. Next slide, please. You may have seen this version of the CDC obesity prevalence map before, but the key takeaway here are that new population data from 2022 shows 22 states have adult obesity prevalence at or above 35%. Which is more than double than the number of states from 2018. But just 10 years ago, no state had an adult obesity prevalence or above at 35%. This might highlight the need for population-based intervention to ensure that all people have access to healthy food, safe place for physical activity, stigma-free obesity prevention and treatment programs, and evidence-based healthcare services. Next slide, please. As previously mentioned by the previous presenter, being overweight and obesity are linked to a higher risk of getting 13 types of cancer. I would like to emphasize that being overweight and having obesity doesn't mean that someone would definitely get cancer, but it does mean that they're more likely to get cancer than if they kept a healthy weight. These types of cancers related to obesity and overweight make up 40% of all cancers diagnosed in the United States each year. There are many factors that can affect individuals' weight, including genes, age, gender, lifestyle, family habits, culture, sleep, and even where they live and work. Some of these factors can make it hard to maintain or achieve healthy weight. For some families, including families of color, those living in rural communities and territories, and low-income families, structural inequities such as disparities in education and economic opportunity and lack of access to healthcare, safe housing, and transportation make the impact of hunger and diet-related disease even more severe. Next slide, please. This is one of the reasons that back in 2022, the White House convened the first conference on National Strategy on Hunger, Nutrition, and Health to catalyze and coordinate strategies to drive transformation and change the country. President Biden hosted the White House Conference in Hunger, Nutrition, and Health to catalyze action to help millions of Americans struggling with food and obesity and diet-related disease like diabetes, obesity, and hypertension. Next slide, please. To advance this goal, President Biden and the Biden-Harris administration released a national strategy identifying ambiguous and achievable action across 5 pillars: improving food access and affordability, basically ending hunger by making it easier for everyone, including individuals in urban, suburban, rural, and tribal communities and territories to access healthy food, integrate nutrition and health, prioritizing the role of nutrition and food security in overall health, empowering all consumers to make and have access to healthy food choices, foster an environment that enables all people to have easily make informed and healthy choice to increase access to healthy food, supporting physical activity for all, making it easier for all to move and remain physically active, and enhancing nutrition and food security research, improving nutrition metrics, data collection, and research to inform nutrition and food security policy, particularly in issues of equity, access, and disparity. Next slide, please. The White House challenge to end hunger and build healthy commitment was a nationwide call to action to stakeholders across all of society to make commitments to achieve President Biden's goal to end hunger and reduce diet-related disease by 2030, all while reducing health disparities. Just a couple of weeks ago, the White House announced 141 new commitments from the health system, payer, nonprofit, philanthropy, academic, and local levels, totaling almost $1.7 billion as part of the White House challenge of end hunger and build a healthy community. The new commitment builds on the $8 billion in commitment announced at the historic conference back in September 2022. Next slide, please. The Biden Cancer Moonshot has spurred tremendous action across the federal government and from the public and private sectors, building a strong foundation for the work ahead. So much of the progress being made is due to the better prevention and early detection. In order to build on this progress to prevent more than 4 million cancer deaths by 2047, and to improve the experience of patients, families, and caregivers facing cancers, we need to continue to equitably improve access to the tools and methods we know work today. Those efforts include reducing diet-related disease by 2030, all while closing disparities among the communities that are impacted the most and ensuring that everyone have access to healthy food. Thank you very much.
Thank you. I want to thank all of our speakers. Want to bring them all up on the gallery here so I can see you all. We do have a couple questions, and I want to just ask briefly, and maybe each of you can answer because they're complex questions. But let me just tell you that we need your answers to think, make it simple in terms of policy direction. So the big question was really, from research, there's lots of challenges to, especially Latinas, women in our communities. And I'll just say it's not only Latinas, it's African American and Native American, who have this great challenge of dealing with obesity or overweight. So why is it that we have late diagnosis? What can we do to decrease late diagnosis, late or not even having very limited genetic screenings, and less completion of treatment? So these are issues of access, but there's also bias involved in our healthcare system. But what do you think would be a strategy to reduce these challenges? And Dr. Jean, let me start with you. You just finished them.
Thank you. Great question. I think one of the things we need to do is meet the population where they are. As we all mentioned, access is one of the big issues. I think when it comes to a certain population, especially the our population, the BIPOC population, we are at work most of the time. So maybe some of the screening can be done at work, education where they are meeting access to them. A lot of times this population, as we mentioned, as I'll share the data, it's when they go to the doctor, they hear the first time of the word cancer or anything like that. So meet them where they are and make sure that the education and the screening are available to them, not just when they go to the doctor, but at community center or even any activities are going in the community where they are and they can learn about it.
Oh, so more community education and more grants to community-based organizations. Okay, Dr. Mackenzie, what would you say to our audience? What's a strategy?
Yeah, I think it's very important to fund places where community goes to. For example, community health centers. We need more doctors that look like our patients. We need more funding to these centers so that way we can have more patients coming to the centers. I personally work part-time at a federal qualified health center, and I'm the only Hispanic female physician at this center. And we have lots of Hispanic patients that obviously they want to see a Hispanic physician because they want to see somebody who understands the culture. They want to see somebody whom they trust. So it's very important to fund these centers. Our patients come to these centers. So these are the places where we can start doing a lot of prevention, but we need funding. These centers need a lot of funding to do all this work. So, and obviously with the work of NHMA also, supporting all the medical students, supporting all the even pre-meds, all the students that are coming through the pipeline, because we need doctors at these centers. And there's not enough of us for all the community.
Thank you. And Dr. Teras?
Yes, thank you. So I would say, in addition to all the great ideas that have already been brought up, that one of the most important things that I think that we can do, looking at a broader scale, as I mentioned in my remarks, is to make it easier and more affordable for people to access healthy foods. Many neighborhoods where Hispanic people are living, and also people in more impoverished communities, the closest place to get food is a convenience store or a gas station where it's cheap and easy to grab highly processed foods, but hard to get healthy foods that help people maintain a healthy body weight. Insurance is a huge factor, not just the uninsured, which is a huge issue, but also underinsured. You made reference to coverage for genetic testing and other more expensive aspects of care. This is a huge issue. Even if people have jobs and have insurance, they may not be covered to get all the best care that they can get. We talked about late stage of diagnosis, but there's also delays in treatment. Even when people have been diagnosed, sometimes there's long delays of 90 days or more more so often in communities of color or patients of color. This is in part because facilities are backed up, facilities have too many patients to care for, and it's also because the patients themselves have jobs, have difficulty stepping away from childcare and their work responsibilities to come quickly and make their own health a priority. So helping people both with those individual barriers and also the broader community barriers to making healthy food and exercise an easier thing to do as part of everyday life are things I think would help.
So I know that we are at time. I just want to mention there is one question that that really focused on affordability of the high cost obesity drugs that are now showing to be very effective with minimal side effects, I think. And just as a policy measure, I think we need to think about the TROA Act as one way to have Congress decrease the barrier through Medicare. And the question was, how is the federal type programs that are given mandates and requirements from Congress, policies from Congress, what is the status of coverage for these high cost drugs? And let me just tell you that the federal insurance, if you work for the federal government, if you work for Congress, if you work for HHS, if you work for any of the federal agencies, you have coverage for these medications in your insurance plans. If you are a veteran, the VA is covering. And if you are military that has the TRICARE, you have coverage. So the insurance companies in our country are actually covering these drugs, but it's a plan by plan approach. And I would educate people to let them know that they have to see what they have to ask their insurance or look at their insurance plan. What is not covered is Medicare. And in terms of Medicaid, Medicaid does cover in certain states, but that's because states have options. And I just want to say that FDA just last week called for the coverage of the obesity drugs now for heart disease. And I think that there is a recognition of the importance of the decreasing costs of complications of heart disease and cancer because of obesity and how we do need coverage for medications. And I hope that Congress can step up to the plate to keep moving forward in creating affordable treatments for obesity and cancer, and also to increase access by thank you all for all of the great ideas for our policymakers in Washington, D.C. here in 2024, when we have so much people having to deal with obesity and cancer. And thank you all very much. And thank you to our American Cancer Society support. And also I want to just give a shout out to the companies that we actually work with through our National Hispanic Health Foundation Corporate Advisory Board, and that is Novo Nordisk and Eli Lilly, who have been champions for the TROA Act too. So thank you all very much. And thank you to the participants. Welcome you again for our next congressional briefing. And please join us at our 30th anniversary summit on the nhmamd.org website. You can register. It'll be here in Washington, D.C., April 12 and 13 at the Hyatt Regency Capitol Hill. And I will personally get Dr. Ruiz to come. Thank you very much. Bye.